Dr. Charles Senteio, who is the professor at Rutgers University and also was formerly the Martin Luther King Scholar at MIT.
Thanks so much, Freddie. I appreciate it. It's wonderful to be here. So anyway, thank you for the opportunity, Freddie, and I commend the attendees here to work on such important and pressing issues. I'm going to talk just briefly tonight about persistent challenges to address health equity, specifically around social determinants of health and how they could be used and should be used to inform clinical decisions. So thank you for that wonderful introduction, Freddie. So I want to just start really quickly. What is health equity? At a high level, it's differences in health status between groups, and these groups can be cut in many, many different ways. And certainly in the past year and a half or so, inequity has gotten much more attention, and I think that that's a good thing. Illumination of these persistent structural issues that we know result in health inequities will welcome additional novel approaches to addressing them. And events like this is certainly a great way to sort of share ideas and put a dent in some of these persistent issues. The pandemic obviously has made sort of racial inequities front page news, and that's something that is again important, and I applaud it. And the tent is a big one, and I welcome other disciplines and other people to become involved to try to address some of these persistent issues. Just some really quick facts that I like to sort of ground and have a common understanding. Infant mortality rates for Blacks is more than twice that of whites. And in Milwaukee, which is an interesting city to look at health inequities, infants born to low SES households are 3.5 times more likely to die in the first years of life. And there are many different statistics that illuminate these racial inequities. When did racial inequity, health inequity emerge, and why? Well, racial differences in healthcare are present at the very inception of health records being kept in the United States. Up until and through the Civil War in 1861, physicians debated whether already well-known racial inequities or racial disparities in health were due to biology, because simply Blacks were just genetically inferior, or social factors, because many Blacks were enslaved and all lived in a society steeped in white supremacy, one in which Blacks' minds, souls, and spirits just didn't matter as much as white people's. At that time, the debate was deeply rooted in politics, as anti-slavery physicians, which included the first generation of Black doctors, at least in this country, argued that social factors were the drivers. These factors were, at the time, defined by the need for cheap labor, and those conditions were what determined both the progression of disease and the health status of enslaved Blacks, mostly in the South, and impoverished Blacks in the North. The biology versus social debate about the explanation for racial health disparities persisted until W.E.B. Du Bois' seminal work in 1899, The Philadelphia Negro. Du Bois contrasted the biological point of view in his observation that, quote, social advancements and vastly different living conditions under which Blacks and whites lived were the drivers of racial health inequities. Du Bois, the sociologist, argued that the causes of racial differences in health were multifactorial. They were primarily social. I submit that Du Bois is as significant to health equity research as the London physician John Snow is to public health. As many of you know, Snow's research found that cholera was spreading through contaminated water. This is a picture of the Broad Street pump, which many of us in public health are well familiar with, which conflicted with the scientific truth at the time, which was that cholera spread through the air. Another example, or an example of how science, quote unquote, hadn't quite reconciled the facts quite yet. But back to Du Bois. He went further, I posit further than anyone up to this point, in making the argument for social factors. He observed the apathy to the disparities. And at times, I think we still don't care quite enough. We still don't behave often enough as if Black and brown lives matter, or matter as much as other lives. Du Bois talked about social advancements and vastly different living conditions. He did not use the term social determinants of health, but as we'll see, he was talking essentially about the same thing. But for the purposes of our discussion tonight, I want to point us to a particularly poignant quote from the Philadelphia Negro. The most difficult social problem in the matter of Negro health is a peculiar attitude of the nation towards the well-being of the race. There have been few other cases in the history of the civilized peoples where human suffering has been viewed with such peculiar indifference. I have it bolded for emphasis. In fact, social factors have been identified for quite some time. Social conditions' effect on health outcomes was described in the mid-1800s. A Prussian doctor described that hunger, illiteracy, depression, and poverty were factors in typhus outbreaks in the coal-rich region that is now Poland. So in the US, for over 100 years, social factors, again, as I mentioned, social determinants of health, which some of us, of course, are familiar with, not genetic factors as was speculated, has been described as primarily causal factors, or the primary causal factors for racial health disparities. Things like financial strain, environmental factors, access to healthcare, access to safe physical activity, access to healthy foods. So it's important to understand the context for which and the long runway of research that supports the impact of social determinants of health. Again, many of us are probably familiar with these factors. Again, Du Bois observed social advancements in vastly different living conditions, which we see across the 5 central social determinants of health: economic stability, education, social and community context, health and healthcare access, and neighborhood and built environment. I want to emphasize here that social determinants of health are not like gravity, a kind of natural law that just sort of happens. These drivers are the result of institutions that create and sustain them. These institutions are populated by individuals who either actively make decisions to maintain inequity or passively maintain inequity by simply looking the other way, by not caring quite enough for the least of these. When I first started studying health inequity around the mid-2000s, like many, I thought the healthcare system was broken. Maybe not. Perhaps it's like the criminal justice system. There are researchers who suggest the criminal justice system is not broken. It's operating just as it's designed to operate. According to the Federal Interagency Reentry Council, the cost of imprisonment in jail in the past 20 years has grown at a faster rate than nearly any other state budget item. It costs about $80 a day to house an inmate, and the United States spends in excess of $68 billion a year on corrections, federal, state, and local. I point this out because we should never assume that we're all united in our desire to eliminate racial inequity. Social determinants impact everyone, but not everyone equally. Social determinants impact specific groups more so, disproportionately, older adults and children. Children, especially critical, given that their physical, social, and emotional capabilities develop early in life, and they provide a foundation for life course, health, and well-being. These nature-nurture interactions occurring early in childhood development can hold impact far across the lifespan. And systematic racism and colorism are types of determinants which do not impact groups equally. Social factors, these determinants, are the primary causes of racial inequity for common conditions, and as we know now, COVID-19 outcomes. Racial inequities for COVID outcomes emerged early in the pandemic, and various risk factors were explored. Again, the nature or the biological versus social argument or debate emerged early in the pandemic, where there was speculation and research around Were there genetic factors that predispose certain populations to infection, to hospitalization, to death? We found that that is largely social factors are at play in these inequities. Primary risk factors like greater proportion of essential jobs, these essential workers, the number of people in a household, etc. So very early, I intentionally have these dates here. These are papers published in 2020. Risk of infection, hospitalization, and death mirrored persistent racial inequity for common chronic conditions like heart disease, diabetes, and cancers. And as we've seen, just as medical care alone has not eradicated racial inequities in health, medical care alone will not result in racial inequity for COVID-19 and other health conditions. I want to talk just briefly about how we perceive structural inequities. What are they? Structural inequities, systematic disadvantage of one social group compared to other groups with whom they coexist that are deeply embedded in the fabric of society. The US narrative, interestingly enough, draws this distinction between the past, say, pre-1950s, and the present. What's the past? What happened? What happened, at least in this country? The narrative asserts that until the 1950s, US history was impacted and shaped by slavery, American Indian removal, lack of rights for women, Jim Crow segregation, period of nativist restrictions on immigration and waves of mass deportation of Hispanic immigrants, eugenics, the internment of Japanese Americans, Chinese exclusion policies, criminalization of homosexual acts, and of course, much more. After the 1950s, civil rights, women's liberation, gay rights, disability rights, movements, and their aftermaths may contribute to a narrative that social, political, and cultural institutions have made wonderful progress towards equity, diversity, and inclusion. Highlights include of the many signs of progress: the Civil Rights Act of 1964, Voting Rights Act of 65, Fair Housing Act, Title IX, educational amendments passed in 72, Americans with Disabilities Act, and of course the Patient Protection and Affordable Care Act. These are, in fact, changes. However, as discussed, racial inequity due to structural factors suggests that the distinction between the past and the present is not so clear. It's vital also to understand perceptions given the persistent inequities, given, as was stated earlier in an earlier speaker, the disproportionate mistrust, and of course, the proliferation of mis, mal, and disinformation. Early in the pandemic, I speculated that social determinants of health, I and other health equity researchers, combined with the dynamic of people of color having high medical mistrust and this proliferation of mis, mal, and disinformation may be exacerbated by existing perceptions based on historical and contemporary factors. And what we found early is that COVID-19 vaccine perceptions, existing perceived discrimination in healthcare, actually plays a role in health outcomes, because these, in fact, are among social determinants. Technologists have great potential to improve the collection and use of social determinants information to inform clinical decisions. However, I must caution us, those of us who are enamored with and work with technology, that the developers of health information technology, like me, may actually exacerbate inequity. Intervention-generated equality, IGI, is a glaring issue. Health information technology interventions may disproportionately benefit more advantaged people. And inequalities are observed at each stage of intervention: efficacy, access, uptake, lower SES. So these social factors play a role in technology uptake, technology use. And anyone that has tried to use a patient portal on a phone can probably relate to what it's like for people, those of us who must access or do primarily access health information via or access technology, access the web through the technology of the phone. So technological interventions do work, but they may work better for those who are already better off. And this is a persistent issue for all researchers and developers of health information technology. And I deeply encourage the participants of this weekend's hackathon to take a close look at our historical factors, how long we've known causes of health inequity, and the role of technology, just to ensure that we're not exacerbating existing known issues. And with that, I like this graphic, which pulls together the social determinants of health, and I welcome comments and discussion.
Thank you so much, Dr. Senteio. It's really great talk about social determinants of health and the importance of really taking into account all of those components as people think about health inequities and the issues that are underlying it.